afternoon, everyone. Welcome to Humanities at the Heart of Healthcare, or H3, proudly brought to you by NHG Group Clinical Education in collaboration with the Institute for Humanistic Medicine, HUME. Our tagline, Real Talk for Real People for Real Practice. Today, we are diving into the topic of practical and ethical implications of regulatory standards of medical advice. My name is Aaron, Director of HUME, and I'll be your host and moderator today. A few quick housekeeping notes. Today's session is MME eligible. Clinicians who attend at least 80% of this webinar will receive MME points captured automatically with your login duration. Your MCR numbers were collected at registrations, so please do not type them in the chat. Use the chat instead for your questions, comments, and feedback. We really want to hear from you. The format today is a 30-minute talk, followed by a 10-minute reflection from our clinician discussion, and then a 15-minute Q&A. At the close, please do fill out our feedback form. This is really important as it shapes, your input shape our future series. This is the second of 5 MME eligible H3 webinars planned for 2026. For you like to know more about upcoming events, please sign up with the HUME mailing list or go to our website at the close that will be available at the closing slides. Before we begin, I want to say something about what we are trying to do at the HUME H3 webinars. Our goal is never to hand you a checklist, word instruction, or clinical protocol. We cannot give you such neat answers to hard questions. What we are here to do is to interrogate how professional standards, ethical, empirical, medical, legal, actually translate into the messy, high-stakes reality of clinical practice. And as you will quickly find, the translation is rarely neat, and trade-offs need to be made and justified. This is highly discomforting, especially when stakes are high, values clash, goals are misaligned, time is short, and when there is no one right answer, the one right answer is elusive. If you leave today with a little disquiet, that is really the intention, because it is precisely while we take time to dialogue, reflect, and wrestle with the discomfort that we sharpen our thinking, deepen our humility, assuage somewhat our discomfort, and over time and deliberate practice cultivate professional wisdom. Our speakers today have reflected deeply and wrestled with this topic at hand, and so who better to share and to guide us into how this has shaped and transformed their clinical practice. Associate Prof. Anantham Devanand, or Dev, is the director of SingHealth Duke-NUS Medical Humanities Institute, head of SingHealth Duke-NUS Lung Center, chair of the National Medical Ethics Committee, and director of the SMA Center of Medical Ethics and Professionalism. Dev is the director of one of the more as director of the more established Medical Humanities Institute at SingHealth. Dev is really like a big brother to the baby brother HUME. On a personal note, I must say he has been a generous older sibling, collaborator, and a true friend to HUME, speaking at our recent E3 Medical Humanities Conference and again today. Significantly, I'm delighted to say that HUME has been invited to be part of the 4th Singapore Medical Humanities Conference in October 2026. And the flyer was shown in the slides in the beginning. This is actually organized, and I hope that everyone will sign up. Now, Charmaine actually really needs not much of an introduction. She's a senior consultant emergency physician at TTSH and director of the Clinical and Patient Engagement Office. Charmaine holds a Master's of Law in Health, Law and Ethics, and is one of the key faculty members at HUME, also contributing immensely to the upcoming MME e-learning modules. She brings both rigorous as well as deep empathy to everything she does. And this is actually her 3rd outing with us. And the previous 2 talks have actually garnered the highest attendances as well as the very positive feedback. So it gives me great pleasure and a genuine excitement to welcome first Dave and then Charmaine to the stage. Over to you, Dave.
Thank you, Aaron. Give me a minute to load my slides. I presume you can see me and hear me. Well, thank you once again, Aaron, for that very kind introduction. And I want to congratulate Hume for putting together a really outstanding E3 conference. Before I start, I want to, apologize a little bit for the slightly clunky title. This title actually reflects research work that is in progress, which is why it is framed in such a specific way. So the scope of this talk is I'm going to start off by describing to you what I mean by regulatory standards of medical advice. And then I would share with you my literature review on this matter, followed by sharing a little bit of my empirical research. And then I'll try and put all of this together and describe some of the tensions that actually trying to adhere to the regulatory standards has created in my own clinical practice. I hope that will take us through half an hour. Now, I want to start with some disclaimers. This is not meant or targeted as an introductory talk. So this talk actually assumes the audience has some understanding of what it means to take informed consent from a patient. I will not be explaining to you what is the requirement from the SMC Ethical Code and Ethical Guidelines, the ECEG. I will also very briefly talk about Section 37, and there's a lot of nuance in that. And again, I'm not going to be covering that. If you think of these ethics talks as trying to provide solutions, as Aaron mentioned, real life is actually quite messy. And part of what I'm going to do is actually highlight more problems than solutions, right? But what I want to say is that regardless of what you think you're hearing me say, regardless of what you think I may be trying to convey, please adhere to the Ethical Code and Ethical Guidelines. Please adhere to Section 37 of the Civil Law Act, because I don't want any of us to get into any trouble, right? My goal here is not to criticize law or guidelines or anything else. I'm sure all of us here appreciate that the law cannot address every single scenario and every single situation. So the law forms an important function. And I'm just trying to highlight some of the potential gaps. And that is not, again, meant to criticize the law, but largely for us as a profession to look at ourselves and ask how we can respond to this. And at the end, what I'm hoping to do is actually a sort of a call to action. I'm hoping that we will appreciate that our patients need a lot more than merely being adherent to the standard of medical advice. We need to do more for our patients if we are to actually truly help them. Okay, so let's start with the first thing. So this talk is about the regulatory standards. So what exactly are the regulatory standards? So in broad terms, I think these are the two major components of the regulatory standards. One is on the professional side, the Ethical Code and Ethical Guidelines from the Singapore Medical Council. This is from the 2016 edition. And then you have the amendments to the Civil Law Act, which was passed in 2020. And that, of course, builds on legislation from case law, most significantly the Hitchcock judgment, which birthed the modified Montgomery standard of medical advice. And so when you look at these standards, I will give you some of the features that I see are pertinent to this discussion. The first is that medical advice as a thing that doctors and other clinicians do is seen as being distinct from other activities such as diagnosis and treatment. So for diagnosis and treatment, the standard of care that is expected from us would be what we call the peer professional standard. If you go back to English common law, that is the Bolam-Bolito test. For medical advice there is a separate standard. And broadly speaking, that standard is thought of to be what a reasonable patient in that particular situation would want to know. Now, and I told you earlier about the Hitchcock judgment, which is nearly 10 years old now, which was a judge, and the grounds of judgment were written by a court of 5 judges. In that judgment, they reference an earlier Canadian case called Dixon and Pinder, where they mapped out broad categories of information that they thought would be pertinent in most situations. That is the diagnosis of the patient, the prognosis, the nature of the intervention that's being done, the risk of this procedure, and of course the alternatives. And if you look at the regulatory standards, they are framed in terms of compliance. So if something goes wrong, we will check, and you either did this appropriately or you didn't do this, right? Done or not done, compliance. Now, I'm just going to briefly show you the Civil Law Act because it can be a little bit confusing, because the first paragraph seems to suggest it follows purely a peer professional standard, but you will see that the second paragraph says that that first standard, that peer professional standard, is actually subject to the information that a person in the particular circumstances of the patient would reasonably be required to have in order to make a decision. So this is what we call our regulatory standards. Now, I would like to then make some clarifications, right? Because as you can see, even in my clunky title, it is described as medical advice / informed consent. But are these two things the same? Are informed consent and medical advice the same, right? So when we think about medical advice, informed consent, apologies. When we think about informed consent, this is how it is described in the ethical code and ethical guidelines. In fact, our ECEG does not talk about medical advice. It talks about consent. In fact, when the Ministry of Health wanted to look at reforming the standards of advice and of disciplinary matters in Singapore, they formed a work group which was also looking at informed consent. But interestingly, based on the findings of this work group, we eventually got a standard of medical advice, which was in section 37, right? And if you look at the law talks in terms of medical advice. So the Hitchcock judgment, which is what I told you about earlier. So this is an important judgment because this is the point at which medical advice was moved from the peer professional standard in our common law to a reasonable patient standard. And our courts describe medical advice as you can see here, broader than recommendations to what should be done, to advise in its broader sense in terms of information regarding alternative treatments and risks attendant to the various possible treatments. And this is actually what was called modified Montgomery. And in many ways, I think of it as modified Montgomery, not because it came up, this grounds of judgment came up with a 3-stage test and so on, but it modified the original Montgomery judgment, which was from the UK courts, because the original Montgomery judgment was only about the disclosure of risk. But our courts interpreted that judgment and incorporated risk into a broader concept called medical advice, right? So we can ask ourselves, what exactly is this thing, medical advice, that the law seems to be talking about, that our ethical guidelines and MOH, don't seem to be referring to? They talk about informed consent. And if you look at the elements of informed consent as described here, you would think that a nice and convenient place to place medical advice will be in the disclosure part, right? The information that we give the patients before they agree to any procedure. But there's more to this, right? Because they said that advice takes on a broader definition, right? It relates to medical decision-making more broadly. And what do we mean by this? So medical advice is different from informed consent because it also relates to non-treatment. So if you give patients different options and one of them is conservative treatment, and if the patient chooses conservative treatment, we don't actually take consent for conservative treatment. But the patient's decision to pursue conservative treatment is based on the advice that was given by us. Similarly, if a patient adheres or does not adhere to treatment, we don't take consent for that. But they adhere or not adhere based on the advice that is given by us, right? So advice is bigger than just taking consent for procedures, right? And in some ways, we may want to think of this as, is there a difference between taking permission from the patients to do something to them, or are we trying to get their agreement to embark on a treatment journey of some sort, right? So what are we seeking when we give medical advice? So typically, when we ask for consent, we are asking for permission. So we ask patients permission and we give them information so that they can make an informed decision. And from this permission, and if we are given appropriate permission, we are protected against assault and battery, because you obviously need permission before you even touch a person, let alone do procedures on them. And obviously, if you've given them enough advice, or if you've given them enough information to make an informed decision, you've got permission, and so you're protected against negligence. But when we give advice, we're doing more, right? We are seeking agreement. And when we get agreement, and that includes, as I said, non-treatment and adherence on top of all the interventions and treatment that are given, we're actually building therapeutic alliances, right? We're building adherence to treatment, and essentially we're building a partnership. We're building a treatment plan that we are embarking together with the patient, all right? So I hope that gives some clarity on how to think about informed consent versus medical advice, and how the law actually places much bigger requirements on the medical profession than just informed consent, right? Our ECEG talks very firmly about informed consent, but the law expands this to advice. The next challenge that I've often had with the law is this idea of what exactly is medical advice? And is that different from medical information? Now, if you look at Section 37, for example, the heading of Section 37 tells you that this is the standard of medical advice. But if you read the text of Section 37, they only talk about information. Right? What kind of information the patient would know, what kind of information the patient would, in the same circumstances as the patient, would want to know, and so on, right? In different places, information that is material, if it is evident from a specific query, and so on. So it's all about information. And then we have to ask ourselves, right? Is there more to advice than just giving information? I mean, is the law just telling us to be some sort of information bureau? Are we supposed to be like some sort of search engine where patients come to us and we just give them information? Or does advice play some other role, right? Is there a role for advice in terms of prioritizing information, persuading the patient, emphasizing certain elements, and so on? And that is not actually addressed by either the ethical guidelines or Section 37. So with all of these challenges in my mind, right, you can see I've obviously thought about medical advice for a little bit, and clearly it doesn't address everything that, it addresses many things, but it doesn't address everything that, that I would think that would be necessary for my own clinical practice. And with this in mind, I did a literature review and I looked at empirical data, because I wanted to go away from just opinions. I wanted to see what patients really wanted, right? So this is my search strategy, and it's, is a PubMed search, and that may be a limitation. And beyond these search terms in PubMed, I also did a wider search across the whole of the internet on patient preferences for consultations and decision making in the Singapore context, so beyond PubMed for that. There's a lot of data, and I'm not going to go show you study after study after study. I'm just going to highlight 3 papers, which I think spotlight different elements. So this is first a systematic review. It looks at the preferences that patients have regarding medical consultations, right? 316 papers reviewed since year 2000. And you can see they identified many different things that patients wanted from their doctors when they consulted them. And I've circled 2 areas, which shows you that patients do want information and they do want to have an active role in making decisions. So the law and ECG are right in setting patient-centered standards for this. But there are also 14 other areas which the law doesn't cover, right? So I hope an uncontroversial conclusion from reading a paper like this, and as I said, this is a systematic review, so there are many, this represents many papers involving thousands of patients, is that adequate medical decision-making is not all there is to getting good healthcare. Because I don't want doctors to think, oh, all I need to do is satisfy Section 37. All I have to do is satisfy informed consent, and my patient is getting good healthcare. That's not true, right? Adequate decision-making is not all there is to getting good healthcare, and there is empirical data for this. So now let's look at the decision-making itself. Again, a systematic review. Here, 45 papers are being reviewed, and we are looking at what facilitates or what inhibits decision-making, and specifically shared decision-making. And at the periphery of these concentric circles are things that we would think would be very expected. Things like continuity of care, privacy of environment when you're talking to the patient, adequate time to talk to the patient, not being rushed. But if you look at the center of what's needed for decision-making, there are 2 concepts: knowledge and power. And by power, they mean patients being empowered or feeling empowered to make their decisions. But if you look at the knowledge side alone, that too is divided into 2 parts. One is the knowledge about the patient's disease, condition, options, outcomes. That is all the information that Section 37 and the law and regulations tells us to tell patients. The other part of knowledge is actually self-knowledge, because if a patient doesn't know their own values, their own beliefs, and their own preferences, they won't be able to use values, preferences, and beliefs to make any decisions, right? And this self-awareness is much harder to come by than many people think. So even if you think about it, even in decision-making, the law addresses a very small part of decision-making. Just this knowledge about the disease, condition, options, and outcomes. It doesn't address, obviously, it doesn't address patient self-awareness of values, preferences, and beliefs. It doesn't address power. It doesn't address any of the other things. And so I hope another uncontroversial conclusion from this is that adequate medical advice is not all there is to good decision-making. So the law does not address all elements of decision-making, right? It specifically focuses on medical advice. And this is not all there is to decision-making. And if we, as clinicians, think, oh, that is the minimum that's required by the law, and we stop there, we are not doing what our patients need. Now let's show you the Singapore context. This is a study by the National Council of Social Service. It's a study using a WHO questionnaire on seniors and pre-seniors. And on the y-axis, you have quality of life. And on the x-axis, you have the desired improvement. And you will see that the domain of personal beliefs, if you go and read the descriptor of personal beliefs, that is the domain that tracks most closely with what we are trying to do with patient autonomy, right? We're trying to help patients make decisions in accordance with their own preferences, beliefs, and values. This is the domain. And this domain is the domain that our citizens, our seniors and pre-seniors score the lowest in. But it is also the domain that they want to see the least improvement. In fact, they want to see improvements in psychological well-being, level of independence, and physical well-being, right? They want other things. So again, I hope an uncontroversial conclusion from this is that adequate medical advice is not all that there is to getting good healthcare in Singapore, especially from the patient's perspective and especially from the perspective of the people who need the most healthcare, our seniors and our pre-seniors. Now, given this literature review, I decided to delve in and try to figure out what about decision-making did patients value and what are the things that they didn't value or they didn't like, right? And because I'm a pulmonologist, I went and interviewed COPD patients. Yeah. I was actually looking for patients with chronic conditions because that is, again, a major component of our healthcare system, right? So I looked at COPD patients and I asked them about their decision-making preferences. And I also interviewed the healthcare providers who looked after these patients, right? There are many reasons to interview COPD patients. I will not delve too much into this, but one of the main reasons, before I go into the main reasons, I also want to show you the characteristics of the patients I interviewed, the demographic data, as well as that of the healthcare workers. And I hope that you will agree that there's at least an attempt to get a diversity of views from this data. Now, one of the main reasons I chose this clinic was because these patients were given patient education. These are patients who came to the same clinic over and over again. So there was continuity of care and they got patient education about their disease. I didn't want health literacy to be a barrier, right? So these patients obviously were given leaflets, which you can say, well, I'm not sure how many of patients read this. It was given in different languages, which may be a bit better. Their children they were also given, pop-ups on their phones every time they tried to pay their bills or make their appointments. But the real education was not given by the doctors, right? The real education was given by someone we trust. It was given by nurses. And the reason we trust nurses is because they checklist everything and they tick off as they checklist and they sign it and they file it. So these patients were given a 37-point checklist patient education, every single visit signed and ticked off, right? So good faith attempts to inform the patient and give them medical advice. So how much did they understand? Well, this is important because if we say that our regulatory standards are focusing on information, which they are explicitly in the text, then we are assuming that our patients, if given information in bite-sized chunks in the language they can understand, that they can process this information and use this information in a meaningful way to make choices. And if you look at what our patients thought about what they had, maybe many of us will not be surprised that actually they had a very poor understanding of their disease, right? They were talking about their disease in terms of bubbles. Many of them did not even connect it to their smoking. And even the clinicians who looked after them almost had a, fatalistic approach to the whole thing. They said, these patients, they're not interested in why and how. They just want to be told what to do, right? And I don't know whether this resonates with the kind of chronic patients that you see as well for your own condition. And then I thought, well, maybe this is a problem with outpatients in this clinic, or maybe it's a problem with COPD patients. But if you look at the health literacy in Singapore, especially among seniors, as you can see in the boxed area, it is not high, right? Singapore's literacy rate is very high, in the high 90s. But our health literacy, and this is just functional health literacy, it is not the kind of literacy that's required to make complex decisions. This is just basic understanding of disease. As you can see, over 40% of our seniors struggle with basic functional health literacy. And there are multiple papers in diabetes, in asthma, in rheumatoid arthritis, in hypertension, all reflecting this exact same data. So this data is triangulated. Our patients struggle with understanding their disease. And so you ask yourself, if patients have difficulty understanding even very basic biological mechanism of disease, how on earth are they making complex decisions or even simple decisions for that matter? Now, if you look at decision making in psychological dimensions, and you can plot self-efficacy, meaning the ability to process information on the y-axis, and locus of control on the x-axis. So if you have an internal locus of control, you feel like you control events in your life. And if you have an external locus of control, you feel that your life is controlled by external events. Then you can divide patients with high or low efficacy as well as internal or external locus of control. And I would submit that the patients with an internal locus of control who feel that they are in control of their lives and who have high self-efficacy in terms of being able to process information, these are the patients to whom the regulatory standards will 100% apply. 100%. There's no doubt about it, and we should absolutely give them the information they need. But the real question is, where are our patients? And my data shows that my COPD patients are actually in the external locus of control, and they have low self-efficacy. And to these patients, actually, information can be counterproductive and confusing and bewildering, and they almost wonder why you're even telling them this data. Now, the other part about my COPD patients is that at this clinic, these patients had to make a whole list of different decisions, which was great for my research, right? They had to make decisions on lifestyle interventions, smoking cessation, exercise, diet. They had to make decisions on chronic medications, not only for COPD, but all their comorbidities. They had to make decisions on procedures, biopsies, scopes, surgery, and so on. They had to make decisions on equipment like oxygen therapy and non-invasive ventilation, chronic. They also had to make end-of-life decisions. And what I found was that for each of these decisions, the kind of information exchange that occurred, the kind of decision-making process that went on, the kind of help the patients needed was all different. If you look at the procedures, the patients may have been told a lot of things, but they only remembered the risks. And that was front and center of their minds. And doctors overwhelmingly documented risks. When it came to equipment, if you need oxygen or NIV, patients don't really feel like they have a choice. It's really the physician who almost paternalistic says, you need this, you have to have it. And then when it comes to lifestyle interventions, doctors and nurses can talk themselves blue, but it's really up to the patient, because in order to make a lifestyle intervention, the patient is in the driving seat. So we found that the nature and quantity of information for each type of treatment that was recounted by research participants was very different from one group to the next, right? And this is very different from the grounds of judgment, right? So the conclusion that we drew logically from this is that a single process for providing advice or having fixed categories of information that needs to be communicated for all types of therapeutic interventions, let alone medical advice more broadly, is unlikely to be meaningful to most patients, right? The one size fits all is just not going to work for our patients. So that brings me to tensions in clinical practice. Now, what do I mean by tensions? Tensions occur when you're trying to do two things at the same time, right? I am trying to adhere to Section 37. I am trying to adhere to the ECEG. I'm also trying to help my patients. And when I'm trying to achieve both of these things, which are both good, that creates a stress. And I'm finding it difficult to identify an accurate balance between them. I know I'm running out of time, and I'm not going to go through all of the different tensions. Maybe I'll just choose one of these tensions to give you an example. So I'll choose the first one, which is goal setting, right? So the tension that exists is, one, we want to respect patients' decision making. We want to respect autonomy. I won't argue with that. But we also, as clinicians, want to protect our patients. We don't want their health to deteriorate, right? So respecting autonomy is important. Section 37, Hitchcock, ECEG. But protecting patients is also important. Clinician Code of Ethics, right? And that's what Healthier SG is all about. But when we allow people to make their decisions, we call this agency freedom. If we inform them, and if they're truly autonomous, they must be allowed to make both wise and unwise decisions, right? And the problem is, if they make an unwise decision, right, if they make less than the best decision that we can see from the medical perspective, what is likely to happen is, because we are often correct, their health will deteriorate, and the future choices that they have will be more constrained because they will start from a worse off health position. So their option freedom in future will be narrowed. So if we give them agency freedom at the beginning, we may potentially constrain subsequent option freedom. And again, if we have broader understanding of autonomy, it becomes more confusing as to which of these two freedoms are more important when we want to give patients freedom to choose. The other challenge, of course, is what happens if we allow them to choose and they start choosing things which come up against the boundaries of what medicine is scoped to deliver? What happens if my patient with COPD wants stem cell therapy? Oh, or what happens if my patient who's beyond a certain age group demands to be put on a lung transplant list and wants to consume limited resources, right? This is also a challenge if we give patients unlimited agency freedom. As I said, I'm not going to go through all the other tensions I have. This includes how we communicate risk, how we manage information overload, where we're trying to give information, but we don't want to overwhelm them, how patients have a genuine need for hope, and how medical advice and how it is framed don't address how we address hope. And then when we give patients all this information, are we actually transferring responsibility of information, of decision-making to them? And do they want this responsibility? And that's another big issue in itself. I'm going to end this talk by classifying these tensions into two different logics that run through medicine. This is work done by the Dutch philosopher Anne-Marie Moll, right? There is a logic of choice, which we can say championed by our Section 37, ECEG, and so on. And there's a logic of care. A logic of choice says what we want to do what patients want based on their preferences, values, and beliefs. That is what autonomy is about. The logic of care is about what patients need. If you think about it, this is what whole of Healthier SG is built on. The logic of choice is a linear process. Doctors provide facts, patients have values, they make decisions, and then based on those decisions, doctors act. Logic of care says, actually, the real world of medicine is not linear at all. Many of the times we don't know the full diagnosis, or the options may not become clear until we move forward or we start treatment before. This whole idea of doctoring, in fact, the word doctoring in the English language is about changing and modifying and adjusting as we go along. In the logic of choice, the doctor's role is to provide information and implement the interventions. In the logic of care, it's doctoring, which is what we told you about. This is individualizing, which is customizing something for that particular individual in front of you. For a logic of choice to work, the options must be clear, right? They must be clearly defined options. You either choose A or you choose B. You choose surgery or you don't choose surgery. These options must be clear, and they're almost binary. For a logic of care, there's no exact point at which you have to make these decisions. They all sort of merge into each other. We treat, we see the response, we adjust, we modify, we treat again. You know, we do a bit and we do not. And then some points we may have to revert to the logic of choice, and there'll be a big intervention. But it's obvious, but it's always a process, you know, and it's open-ended. There's no time bounds to this, right? Our care commitments are open-ended. When we use a logic of choice, you're essentially asking patients to have a balance sheet. These are the pros, these are the cons. These are the advantages, these are the disadvantages. In a logic of care, there is no, I mean, I don't know whether your patients can really sit down and write down pros and cons, but most of the time it is a fluid process with continuous adjustments, and we work with it as we go along. The logic of choice, as we know from the law, is autonomy is good and oppression by paternalistic doctors who don't give information is bad. In a logic of care, attentiveness and being very specific to the patient is good. Neglect and allowing people to make bad choices is bad. In a logic of choice, when something goes wrong, we lawyer up, we want to sit down and figure out whose fault is it, who didn't do what, right? Because as I said, our regulatory standards are framed as an issue of whether it is complied with or not, right? An issue of compliance. In a logic of care, when something goes wrong, we are asking, how can we fix this? How can we make it better? Right? And these don't need to be dichotomous or binary. But I want to highlight this for you because if we are only focused on following or meeting regulatory standards, we are missing the entire logic of care, which in many ways seems intuitive to most of our clinical practice. So my take-home message is that merely complying with the standards of medical advice creates problems that are unintended and really unhelpful to our patients. And that is not my opinion. I hope to have shown this to you based on empirical data, both from Singapore as well as from other parts of the world, not only in lung disease, but in many other chronic diseases, right? So this is supported by empirical data. And when you have this data and you are sensitive to this, then as a clinician, you become very, very stuck because tensions develop, right? You're trying to follow the law, but you're trying to help your patient, and trying to find that balance is a lot harder than what people who just tell you, these are the rules, follow them. You know, that is a very simplistic way of looking at medicine. Of course, I'm not the first one to think of this, right? Honora O'Neill is probably the most famous student of the American philosopher John Rawls. And when the UK was going through similar processes, she pointed out that doctors, like other professionals, find themselves pressed to be accountable and rather than to be communicative, to conform to regulations rather than to enter relations of trust. And I want to end this by reminding all of you that regardless of what you think I'm saying, I am explicitly telling you to follow the ethical code and ethical guidelines, to follow section 37, to follow the law, right? All I'm trying to say is that stopping short of just following the law and just there is you're going to do your patients, or you're likely to do your patients, a big disservice. Thank you very much.
So some reflections from me as a discussant, and coming from my role as, heading the case department in TTSH. Okay, my own self-reflection, right? 2 years ago, I chaired a medical legal conference on informed consent, and I had to confess that the focus was entirely on what the law wants from us and how to practice defensively. Note that I didn't say defensively, not how to practice defensively, but how to practice defensively. And a lot of the work I do and a lot of the teaching I do is from that lens of trying to equip doctors with the ability to practice defensively. But what Dave has done here is something very rare that doesn't happen enough in medical legal education. He's gone back to the patients, and he hasn't just told us what the law says or what the law wants. I think what he has shown us is that we can have legally compliant advice giving that is ethically and practically inadequate for patients. And I think that's something really worth thinking about as clinicians who value, our relationship with patients. From my vantage point of having worked in complaints for as long as I have, I just want to give you a really quick real life example that I hope is very familiar to many of you. Okay, so you're counseling a patient for some kind of procedure, and you mention damage to surrounding structures. Okay, and then you may think, okay, I need to be more specific. I need to tailor it to my patient. So you may specify the structures: bowel, vessel, spleen, and you're really conscientious, and you may even try to avoid jargon like perforation. And so you say, oh, one of the risks is that it could create a hole in the bowel, right? So patients, not any questions, auntie? Okay, no questions. They they give consent, they sign the form, you send them home with the patient information sheet. Unfortunately, during the procedure, that risk eventuates. Bowel is perforated. They spend 1 week in high dependency. There's prolonged ileus. They're then on TPN for weeks. They leave the hospital 5 weeks later and 15 kg lighter. And then the complaint arrives at my office, and the patient says, the doctor didn't tell me, okay? And then the doctor's like, no, I did, and here's the documentation to prove it. And it's true, the first thing I reach for is the documentation. Was the procedure explained? Was the risk explained? Was the form signed? Did we state the risk clearly enough? Very often, actually, the answer is yes. The notes are thorough. The consent form is there, and then I'm like, okay, this one can defend, okay. But why is the patient saying the doctor didn't tell me? Okay. Often when, as the doctor being complained about, we get a bit defensive, or we either chalk it up to, okay, the patient's forgetful. Okay, I did say, but the patient forgot. Okay, or there's post hoc regret. Now that the risk has eventuated, you regret and you say, I didn't explain it. Okay, or we chalk it up to some kind of hindsight bias. But just consider for a moment, now that Dave has given us this lecture, consider for a moment that maybe the patient actually had no idea what it actually means to damage surrounding structures, right? It's a very abstract idea to them. With healthcare literacy in Singapore being the way it is, okay, a hole in the bowel is a very abstract idea. They don't understand what it means, hole, sew it back, lor. They don't understand that and you know what it would have meant to actually communicate rather than to just transfer information of risk would have been to say, okay, there might be a hole in your bowel. What that may mean is longer hospital stay, extra costs for you, okay, possibly some medium to long-term consequences, something like that. And so I hope I have managed to give you a familiar situation and prompt your thinking into how transfer of information and getting a signature on a consent form can be quite transactional. It can theoretically fulfill your legal obligations, but it doesn't mean that you have secured agreement, okay? You may have secured permission to carry out this procedure which you feel is beneficial for the patient, quite justifiably, right? But so it is an authorized procedure, there's permission, but what didn't happen is agreement, a genuine shared understanding of what was going to happen, why, what may happen along the journey. As Dave put it, is a journey, right? Okay, arrived at together between you and the patient. So in summary, I mean, the regulatory standards secure permission, but not necessarily understanding. And Dave's closing quote from Baroness O'Neill is something I want to bring back because I really, really love the thought that provokes. Okay, doctors find themselves pressed to be accountable rather than to be communicative, to conform to regulations rather than to enter relations of trust. Okay, what O'Neill is pointing at is the difference between making yourself defensible and helping the patient own their decision. Both matter, but admittedly, and I'm the first one to tell you this, under pressure, time pressure, volume pressure, medical legal anxiety, we reach for defensibility first. It's literally my job to do so, right? To protect you as doctors, to protect the hospital. It's literally my job to do so. We reach for defensibility first, more documentation, and that drives our own anxiety, more documentation. I keep getting questions on, we're so busy, how to document more, etc., etc. More documentation, cleaner notes, an extra line on the consent form. How do I bulletproof my consent form? Should we add another clause to say this? Should we say that patient, had at least 24 hours with the patient information sheet? All of that. And none of that is wrong, by the way. None of that is wrong. It's a very real pressure that we face. But defensibility is not communication. And actually, it's more often the communication failure and not the documentation failure that generates the complaints that I have to deal with. So I want to leave enough time for questions and all that. So the question I will leave you this is simply this. The last time you gave medical advice or took consent, were you being transactional, or were you being communicative? And is there room really, to achieve both, to again fulfill all of those technical requirements of you, but also to be communicative and meet the needs of your patient. Yeah, and that's pretty much all I have from my perspective and my role. I guess I'll hand the time back to Aaron for the Q&A.
Thanks, Charmaine and Dave. I've really enjoyed the talk and the sharing, but it really created more questions and answers. And I guess it helps us to reflect on our own personal practice. There is a question in the chat, and I'll just read it out. With a logic of care model, this is from Ken at IMH. Is there a risk that when things go wrong, the assumption is that the healthcare professional is the one who made a mistake? And how does this fit in with empowering patients? I'm not sure whether we can actually try at least give our own experience in how we square the practice of logic of care versus our logic of a choice, and what is our heuristic. Clearly there is clearly is a individual practice, but I think what is useful is to see how we square our own logic in terms of this, or how we utilize when to toggle one to the other. Dave, any thoughts at all?
Okay, I will try. So I want to just reiterate what I said earlier. First, the logic of care and logic of choice are not necessarily dichotomous or mutually exclusive. We don't have to choose one over the other. There are obviously benefits of both, and I'm not being disparaging to one or the other. Of course, being a healthcare professional, we tend to gravitate towards the logic of care, but people should be allowed to make decisions for themselves. That's their right, and that right should be well protected. I think that the other clarification I should make before I answer this excellent question is that just because we are calling it a logic of care, we are not calling it paternalism, right? Paternalism is is saying that you know what's best for a patient, right? A logic of care actually can be squared with an autonomy-based model, where there's a whole basis of shared decision-making or patient-centered care. So if we understand what's important from the perspective of the patient, then a logic of care will be built around what the patient wants and believes. It might not mean that the patient is involved at the same level at every single step of the decision making, but at least in broad sense, we have some idea of how this patient wants something done, or a broad paradigm towards their treatment. And this comes back to the relationship building part, right? So the logic of care actually tells us that we need to continue, we need to build the relationships. We cannot, even in a world with AI and all sorts of the technology and such explicit standards, we're not going to be able to, get consent signed by bots, which can, theoretically, answer any question that you put for it, and it can record the entire process, and so on. And then nobody can say, I wasn't given the information, because that's, I mean, I think technologically we're not too far away from that. But I think what I'm trying to say is that I think there's going to be still a role for the relationships. And especially as the person who asked the questions pointed out, when there is an error, the challenge for clinicians is to try and maintain that relationship, right? And I think that Charmaine gave a really, really excellent and illuminating case. And I would wonder, what was said to the patient after the bowel perforation was identified. How involved were the clinicians in not going to the point of saying, no, it wasn't my fault, or this happened inevitably, but you signed the consent form, so I'm off the hook, rather than something has happened, something bad has happened, we are here to try and fix the problem and help you through this. And we understand it's not what you expected, in terms of your recovery. This has prolonged your recovery, it's increased your cost. We want to be empathetic to all of those things that you have really experienced. So my response to the question ultimately is about maintaining the relationship, keeping the communication lines open, and then meeting the patients where they are, and then trying to continue, to care for them, even when something is gone wrong, even when they are looking at you as, you did this to me, and you're saying, yeah, I did it to you because I wanted to help you, but now I'm here to try and help you solve the problem. And that, I think that's the kind of ethos that, I think that might be helpful to us moving forward. Thank you.
I will move to the next question, then I'll chime in, Charmaine. There are two questions that actually, and I'll lump them together. It's really talking about how you balance beneficence and autonomy, but also broadening it to more than just biomedical. How do we take into account the holistic patient? And the questions by Scott as well as Mei Yan actually highlighted this. Can I bring it back to the model that you had, Dave, with regards to the psychological ways in which patients make decisions, and as well as the shared decision-making model, where we are very good at giving the information, but the other part is really knowing the patient and then being, to a certain extent, willing to acquiesce the power difference, engage the patient. The question, therefore, would be, is there a role? Do you triage? Should we triage our patients in terms of what type of a psychological situation they are like, what their context is like, their literacy? Would that be what you would be doing or what we would be doing? Because to be fair, if you do this for everyone, we may bankrupt the healthcare system if we demand that level of nuance for each and every individual patient.
Yeah.
So really, to the two of you, do you all triage patients? Do you say these are straightforward, highly educated, high locus of control, and so on and so forth, and then practice in that nuanced way?
Charmaine, do you want to go first?
Okay, my own personal practice is a bit different because as an emergency physician, I don't have repeat patients, I don't have long-standing, relationships and all of that. But when I teach, it has long been my suspicion that the more educated and empowered the patient is, actually, in a way, the easier it is to defend the process of medical advice and information giving and consent taking, in a way. Because you have the questioning patient, you have the empowered patient, and in a way, it's easier to navigate because the patient will challenge you, will bring their doubts to you, will, all of that, and then you can engage with that and give them the answers. And then later on, like in Hitchcock, when something happens and then they're not happy, they can't then go back and say like, oh, I was, I was inadequately advised when they are shown to be very active participants in their care. The trickier part really is in the everyday patient. We have, like Dave says, a lower focus of self-efficacy, health literacy. Then sometimes it can be very challenging to tease out what it is they need or want. They don't know what to ask you, and then because of that, it really calls upon your skill of relationship building to try and also meet them halfway and understand what it is they want, because they don't know how to ask. They don't know how to articulate, what the hesitancy might be, because they're not there yet. That's where the relationship building comes, and it'll be a bit rich of me to say anything because I don't engage in that in my clinical practice. So maybe this really has to go back to Dave in a way. Yeah.
Okay. Yeah. Well, thanks, Aaron. You actually formulated it into a very complex question because, I heard
My
several
apologies. My apologies.
That's okay. But I want to answer it in parts because so that I address the different parts, because you talked about looking beyond the biomedical sphere when we formulate treatment plans. Then we talked about whether we need to triage patients according to psychological domains or any other domains, right? Literacy or whatever else things that we have. And then we talked about what is practical and bankrupting the system and so on. So I think first is this whole issue of should the biomedical recommendations prevail. I think one of the challenges that we have is that medicine is exceedingly successful. I mean, it is just unbelievably successful. Medicine has succeeded in a way that's beyond the wildest dreams of people who went before us. And because of this, we think that almost anything is possible in medicine. And I think that is one of the challenges that we have. I think there's a certain hubris in the medical profession about this. But ultimately, if you step back away from the huge success that modern medicine now gives with all the biologics and all the proton beams and all the robotic surgery and all those other incredible things that is to be delivered, doctors don't treat diseases. Doctors treat patients, right? So this whole idea of making a recommendation based only on the biomedical recommendations, and I know that includes even genetic level information these days. So I'm not naive to that fact. When people are using scanners to 1 millimeter resolution, genetic profiles, huge big data, and AI, and they are making recommendations. But at the end of the day, they are still treating patients. They are not treating diseases. And if we don't remember that, if we get lost in all the technology, then we will be still stuck in saying, well, shouldn't the biomedical thing, isn't that obviously the best interest of the patient? So I would just be cautionary about how much we might overestimate our own abilities. Now, to the question of triaging the patients, I would actually say that many experienced clinicians actually do this all the time, right? They are, and they have an intuitive feel about this. In fact, you see some of the most experienced clinicians, the medical students are just shocked as to how you know how to talk to this patient this way, how you know how to talk to the other patient in another way. And my seniors, I used to fall at YY Ong's feet. It's like he just knew who to speak to in what way, because the kind of observation that when he sees a patient, he just doesn't see a person standing there. He looks and he's looking at the physical signs, he's looking at the way the patient is dressed, the smell of the patient, who's standing with the patient, the posture of the patient, the body, the body position, the eye contact, and they are taking all of these in, and they are using this in many ways to triage the patient. And then as they speak to the patient, there's almost they're doing this almost reflexly, right? On continuously adjusting what they are listening and the information that they are giving out to their patients. And I would suggest that especially in a world with all this technology, this is a great opportunity for clinicians to use this technology to our advantage and invest in some of the things that we may have a competitive advantage over machines and artificial intelligence over. And then finally about, how much we should engage with the patients, and is it practical, doing all the things I said in every single patient, and that clearly wouldn't make any sense. But I mean, and for a person who's talked about the many limits of the law, I would actually go back to the law on this, and I will tell you the law actually says that how much we need to say depends on the severity of the consequences and the likelihood of the consequences, right? So if something is something bad is going to happen or could happen, I think it makes sense to take the time and pause and to invest in building a relationship and preparing. I mean, even more than the medical, legal, and avoiding complaint, just preparing the patient psychologically. This could happen and you better be ready for it. I mean, let's go back to being good doctors rather than being worried about being sued, right? So I would suggest that we could use, some of that wisdom from the courts in trying to decide for ourselves who are the patients that we need to engage with directly and build stronger relationships. Who are the patients who are not going to require that information, who might even find it frustrating for us to delve into these kind of big, long conversations for something that they want very short and snappy answers to. I hope that sort of answered the question.
I'm wondering if y'all can hear me, because I'm having problems with my webinar. Can y'all hear me?
I
Yeah,
can.
Aaron. Yeah.
Sorry, I will go blind because the buttons are all not working. But I'll sort of want to bring the webinar to a close, because we are running a bit close to the time at the end. Again, thank you very much, Dev and Charmaine. Definitely more questions and answers, but I hope we would be inspired to know that the compliance is only really the base level. And if we do want to practice for decades, if not longer, then obviously there's opportunity for us to improve or even mature beyond just compliance. So I guess this is really quite inspirational in that, we hit the compliance as young trainees, as young doctors, but surely we would want to aspire for more, not just for the patients and not just to not get out of trouble, but really to enjoy our practice. Yeah. So
Very
we have
well
come.
said.
Yeah, so we have come to the end of today's panel discussion and Q&A. There are a few other questions that have come in, and we'll try to answer them subsequently offline. But before we go, there are a few things that we really need to do. Again, thank you very much, Dev, Charmaine, for your thoughtful, insightful sharing and reflections. It helps us as a healthcare community know that the struggles that we are facing is not alone, and that we can commiserate and learn from each other. Thanks for the participants for listening into this webinar. A reminder that there will be upcoming MME and Hume events, so please stick around and know the program. And the last thing is really to get feedback in terms of how we are doing, and really how you want us to improve our offerings in terms of H3. And finally, do sign up for the conference that Dave and his team have so excellently put together. With that, I'll close the meeting, and I really hope that you'll give some time to give the feedback, the comments, and such that we can actually improve the webinar. Thank you so much.
Thanks, everyone.
Thank you.